ENT faculty. So today we will discuss about FMGE 2023 ENT recall. That is the question and answer based on the recall which came in the FMGE exam 2023. So myself, Dr. Prateek Kumar Garg. Let's start. The first question, which of the following is true regarding external nose? So examiner want to ask which of the following is true regarding external nose. And the options are bony 1/3, cartilaginous 2/3, bony 2/3, cartilaginous 1/3, bony half and cartilaginous half, bony 1/3 and cartilaginous 1/3. So let's draw a diagram of external nose. So this is somehow like the external nose is like this. So above there is frontal sinus. This is frontal sinus. And this is my external nose. In external nose, the upper 1/3, on both the sides there is nasal bone. Nasal bone which constitute around 1/3 upper part. Below that, below the nasal bone, there lies upper lateral cartilage. And below that, there is lower lateral cartilage. Lower lateral, or we can say major alar cartilage. So as you can see, this is my external nose. The uppermost part is formed by the bone, that is a nasal bone, which constitute around upper 1/3. Below that, the lower 2/3 part is formed by the cartilaginous part. And this cartilage are upper lateral cartilage and lower lateral cartilage. Beyond the lower lateral cartilage, there are also small cartilages, which are known as minor alar cartilage. Okay, so this is all about the external nose, which is formed above by the frontal bone. The point, the junction between the frontal bone and the nasal bone is known as nasion. So nasion is a junction, that is a bony and bony junction, which is formed between the nasal bone and the frontal bone, that is at the root of the nose. The other point is known as rhinion. Rhinion. So rhinion is a junction between the nasion and nasal bone and upper lateral cartilage. So if you can see, the external nose is basically formed by the bony and the cartilaginous structure, out of which the upper 1/3 is formed by the bone, that is nasal bone, lower 2/3 is formed by the cartilage. So correct answer out of this is bone 1/3 and cartilaginous 2/3. Clear? This is all about the external nose. Examiner wants to know about the external nose, not the nasal septum. One more thing is there. Nasal valve. What is nasal valve? So nasal valve is an area which is formed medially by the nasal septum, laterally by the anterior end of inferior turbinate, and above is lower border of upper lateral cartilage. And this is the narrowest area of the nose. nervous area. So again, one more important thing, nasal wall, medially by the nasal septum, laterally by the anterior end of the inferior turbinate, and above it is guided by the lower border of the upper lateral cartilage. And if we talk about the nasal external nose, above is the nasal bone that is forming the 1/3 part, and the lower is the upper lateral cartilage and lower lateral cartilage, which combinedly forming the lower 2/3 of the external nose. So correct answer for this question about the anatomy of external nose is bony part 1/3, cartilaginous part 2/3. Next question. A patient with Bell's palsy came with deviation of face. Deviation is seen on which side of the face? Now, the patient is having Bell's palsy. We all know Bell's palsy is a lower motor neuron lesion. So whenever there is a palsy over the one side, suppose this is my face. Okay, this is my face. Suppose the palsy is over one side, half of the face. Suppose the patient is having left-sided Bell's palsy. Suppose the patient is having left-sided Bell's palsy. So the movements of this side will be restricted. There will be no muscle movement. There will be no movement over this side of the face. Opposite side of the face, the other half of the face, there will be movement. So deviation will be whenever patient try to smile. So the angle of mouth will be dragged towards the normal side. The eye will wink towards normal side, because the side where there is a paralysis, there will be no movement. So if patient is having Bell's palsy over suppose left side, so deviation will be towards the right side, because left side muscles are not at all working. So whatever the muscles are working, they will push the face towards that side. So the deviation will be which side? Towards the normal side. Deviation will be towards normal side. So that means opposite side, deviation will be opposite side. So out of 4 options, same side, incorrect. Deviation will be towards the opposite side. Now opposite side, upper part, opposite side, lower part. The more correct answer is opposite side, lower part, because the angle of mouth, nasal wave, fold, eyes, these are moving. These are, so lower part of the face will be deviated. Upper part, there are forehead wrinkles. So that will be absent, but there will be, you can see the deviation over the upper half. You will see the wrinkles present over the normal side, wrinkles absent over the affected side, but the deviation will be towards normal side. Let's have a little idea about upper motor neuron lesion and lower motor neuron lesion. Since Bell's palsy is a lower motor neuron lesion palsy, so what is difference between upper motor neuron lesion and lower motor? Upper motor neuron lesion, forehead is spared. Why forehead is spared? Because in UMN lesion, there will be decussation of fibers from both the sides. Like the facial nerve is arising from the pons. So whenever the fibers are coming, some fiber will go to the opposite side. So there will be decussation of fiber. So if there is upper motor neuron lesion, because of decussation of fiber, the same side will be supplied by the fibers coming out from the opposite side. So in upper motor neuron lesion, you have to remember forehead is spared on affected side. Whereas in lower motor neuron lesion, complete half will be affected. Complete half of the face. So one side of face completely affected, as we can see in this picture, complete half is affected here. So that is lower motor neuron palsy. Third question. A 16-year-old male presented with recurrent profuse bleeding from the nose. What would be the treatment in this patient? Option given are FNAC, biopsy, radiotherapy, and surgical excision. Now read out the question again. Whenever a long question is framed, 2-3 points you always keep in mind. First is the age. Age is very important in deciding the diagnosis, in deciding the answer, the correct answer. So patient is 16-year male child. Age and sex. Always look in any of the question, look for the age, look for the sex. So patient is 16-year-old. That means patient is an age group of 10 to 17 years age group, male child, presenting with nasal bleed. Nasal bleed. If patient is presenting with the nasal bleed, a 10 to 17 years age group male person, always think of what? Angiofibroma. There could be nothing else. A patient in the age group between 10 to 18 years of age with a nasal bleeding and the patient is a male, then 100% it has to be angiofibroma. Okay, so we came to know the diagnosis. The patient has angiofibroma with the diagnosis. Now, what will be the treatment? We all know angiofibroma. What is angiofibroma? It is a benign tumor. It is locally invasive tumor. It is pre-malignant tumor? No, it is not malignant. What is the peculiarity of this tumor, angiofibroma? It lacks the muscles in blood vessels. That is, there is no tunica media. Only fibrous tissue and blood vessels are having the endothelial layer, but there is no muscular layer. So no tunica media, and that's the reason angiofibroma come up with profuse bleeding. So any patient of angiofibroma, the biopsy, what are the things which are contraindicated? So FNAC and biopsy or digital palpation is absolutely contraindicated in a patient of angiofibroma. Why? Because that will lead to profuse bleeding. So in a patient of angiofibroma, you can't go for FNAC or biopsy. So these two options automatically are wrong. Now, what is the other treatment? We all know angiofibroma. What is the treatment of choice in any patient of angiofibroma? So, angiofibroma treatment is pre-embolization followed by surgical excision. So, in any patient, treatment of choice of angiofibroma is pre-embolization followed by surgical excision. That is the correct treatment. So, in this question, the answer firstly make out a diagnosis. The diagnosis is angiofibroma because the patient is a 16-year-old male patient presented with a profuse nasal bleeding. So 100% the diagnosis is angiofibroma, and the treatment of angiofibroma is do the pre-embolization followed by the surgical excision. There are different approaches for the angiofibroma, like the Weber-Ferguson approach. Mid-facial degloving approach. Nowadays, what we are practicing is Denker's approach. Denker's approach by endoscopic route. Okay, so treatment of choice is pre-embolization followed by surgical excision. And radiotherapy is only used whenever there is intraceable tumor, intracranial extension. Tumor is going in the brain. There is recurrence, multiple time recurrence of the disease, and the tumor is extending, going in the brain. The main supply is coming from the internal carotid artery, which can't be tied down or which can't be embolized. So in that cases, radiotherapy can be used along with the surgical excision. We surgically excise what of the area we can easily access, and the remnant part, the recurrent part or intraceable part is treated by means of radiotherapy. That is the only role of radiotherapy. Otherwise, the mainstay of treatment in angiofibroma is surgical excision. So correct answer is surgical excision. Question number 4. A 2-year-old male child brought to emergency department. The child was having difficulty in breathing and speech. X-ray was performed. Which among is the best treatment of the above condition? Now X-ray is given. This X-ray is from the front view. सामने से लिया गया है. That's why we can see both the lungs. We can see the thoracic cavity. We can see the cardiac shadow. Okay. So you can see there is one circle that is on the X-ray. What we can appreciate as a rounded structure is there, cone-like structure is there, which is seen like full circle. So in these type of cases, we remember a trick. FFF. F stand for whenever there is a frontal X-ray from the front view and image coin, whatever it is, fully shown. Here you can see the complete circle or coin is visible. So if the X-ray is frontal and the image shown is full, that means the foreign body is in the food pipe. So what do you mean by FFF? F stands for X-rays from frontal view and image shown is full picture. That means if from the frontal view full circle is coming, that means the foreign body or whatever the coin or particle is in the food pipe. FFF. Just remember this trick, FFF. So this is a picture showing the X-ray from the front view with a full circle. You can see the circle is full. So frontal X-ray with the fully shown foreign body, that means foreign body is the esophagus. So by looking at the X-ray, we can easily know that foreign body is in the esophagus. Let's try to understand this better. See, suppose we all know anteriorly there lies a trachea. So trachea is an incomplete ring, and in the trachea, suppose this is my anterior or frontal view. And drawing the picture in a human body. So this is my trachea. And normally my esophagus will be collapsed. Okay. So if I look from the front, since trachea is an incomplete ring, posteriorly there is only the fibrous tissue and cartilaginous part is covering the anterior two-third. Okay. Anterior two-third. So whenever a foreign body will stuck in the trachea, it will be like this, like a slit. If we look out from the front, it will be looking like a slit, like a stand, like a line drawn, because trachea is deficient in cartilage in the posterior part. So foreign body will be more easily fixed like this. If foreign body is in the esophagus, which is already compressed in the horizontal view, so the foreign body will look like this in the horizontal segment. So esophagus, if we see from the front, the foreign body will seem complete ring because it is in the horizontal posture, something like that. Whereas in the trachea, there is a foreign body, it will be look like a slit. So if I'm looking from the front, the foreign body or a coin in the trachea will look like a single slit. Whereas the esophagus, it will look like a complete circle. So front FFF, frontal X-ray, the foreign body is seen fully. That means foreign body is in the food pipe. Food pipe is nothing but the esophagus. Understood? So since we came to know in this X-ray, the foreign body is in the esophagus. Now examiner want to ask which among them is the best treatment of the above condition. So since foreign body is in the esophagus, so bronchoscopy, tracheostomy has no role. Esophagoscopy is definitely having some role because foreign body is in the esophagus. So we will do the esophagoscopy and remove that. So correct answer is esophagoscopy. Now the fourth option is Heimlich maneuver. This maneuver is generally done whenever there is a choking. That means if foreign body is blocking the airway, so patient can't breathe. Patient will be having the choking sensation. In that case, what we will do, we will hold the patient from the behind and will put pressure over this area below the sternum, lower part of the sternum, and we'll put a positive pressure so that the foreign body can come out. So Heimlich maneuver is used whenever there is a choking, whenever the foreign body is blocking the airway. But looking in this picture, foreign body is already in the esophagus, so there is no use of Heimlich maneuver. We have to do the esophagoscopy and remove the foreign body. Question number 5. Which nerve supply above the level of vocal cords? Very easy. Very, very easy. We all know, suppose if I draw a diagram, a sagittal section. This is my thyroid cartilage. This is my cricoid cartilage. The vocal cords, true vocal cords are formed from the conus elasticus. So these are my true vocal cords which are formed by conus elasticus. And the false vocal cords are formed by quadrangular membrane. So these are false vocal cords which are formed by quadrangular membrane. So we all know that true vocal cord and area below that is supplied by recurrent laryngeal nerve. That is, the recurrent laryngeal nerve is the main supply which is supplying the glottis, that is the true vocal cords, and subglottis. We are talking about the sensory supply. Okay, whereas the area above the vocal cord is supplied by superior laryngeal nerve, more precisely internal branch. Superior laryngeal nerve is having two branches, internal and external. So this is the internal branch is the sensory supply. Above vocal cords. Sensory supply above the level of vocal cords. This external branch is supplying the muscle which is known as cricothyroid muscle. Okay, and this cricothyroid muscle is the main tensor of vocal cords. Understood? So above the level of vocal cord, the main supply is by the internal branch of superior laryngeal nerve. Below the level of vocal cords and the vocal cord, the sensory supply is by the recurrent laryngeal nerve. And above the vocal cords, it is superior laryngeal nerve. Superior laryngeal nerve consists of two branches, internal and external. Internal branch is supplying the sensory supply above the level of vocal cords. External branch is supplying the muscle which is known as cricothyroid muscle, which is the tensor of vocal cords. There is only one muscle which is supplied by the superior laryngeal nerve, that is cricothyroid muscle. Whereas all the muscles in the larynx are supplied by the recurrent laryngeal nerve. Now, what examiner want to ask? Which nerve supply above the level of vocal cord? So there are two correct answers, as I can see in the picture. There are two correct answers. The first is superior laryngeal nerve, seems correct. The other one is internal laryngeal nerve. Which is the more correct answer? More correct answer will be internal laryngeal nerve, because superior laryngeal nerve has two branches, internal and external. External is supplying the cricothyroid, internal is supplying above the level of the vocal cords. So if both the options are given, so more correct answer will be internal laryngeal nerve. If this is not in the option, then definitely you could go for superior laryngeal nerve, but more precisely above the level of vocal cord, sensory supply is by the internal laryngeal nerve. And other things what to remember: recurrent laryngeal supply all the muscle, recurrent laryngeal muscle now supply all muscles of larynx except cricothyroid, which is being supplied by the external laryngeal nerve. Okay, next question. What is the function of utricle and secule in the ear? Now, what is utricle and secule? These are part of the vestibule. Let's make a simplified diagram. This is my central chamber, which is known as vestibule in the ear. Anterior to the vestibule, there lies the cochlea. So this is my cochlea. And posterior to the vestibule, there are three semicircular canals. The above one is superior semicircular canal. This is lateral semicircular canal. This is posterior semicircular canal. Above one is superior semicircular canal. The vestibule is consist of two chambers. One is two recesses. The one is elliptical, other one is spherical. So spherical recess is secule, elliptical recess is utricle. So these utricle and secule, which are forming the central part, are mainly responsible for linear motion. That means linear acceleration and deceleration. Then sense of gravity. Sense of gravity is perceived by utricle and secule, and the position of head. So the vestibule, the central chamber, consisting of utricle and secule, which is basically responsible for linear motion, that is linear acceleration and deceleration, sense of gravity and position of head. Whereas the semicircular canal are responsible for angular motion, angular acceleration and deceleration. Whereas this cochlea is responsible for hearing low frequency sound or high frequency sound. So the examiner want to ask, what is the function of utricle and secule in the ear? So clearly correct answer is linear motion. Hearing low frequency or high frequency, these both are function of cochlea. So they are incorrect. Linear motion and angular motion, don't get confused. Angular motion is a function of semicircular canal, not a function of utricle and secule. So correct answer is linear motion. Sometimes examiner is putting like these options so that you may get confused. But make it very clear, angular motion is by the superior, inferior, superior, lateral and posterior semicircular canal. Linear motion is by the vestibule, that is the utricle and the secule. So correct answer will be linear motion. Now identify prominent sinus in the given picture. So this is a picture, what is view X-ray of paranasal sinuses. As you can see, it's a very simple question, nothing fancy in this. This is the orbit on both the sides. Examiner want to ask about these. As you can see, this is my nasal cavity. So on both the sides of the nasal cavity, which is the sinus? Maxillary sinus, very clear, very simple. So on both the sides of the nasal cavity is the maxillary sinus, which is below the orbit. If you want to locate other sinus, this is my frontal sinus. And you can see there are two sinuses. So these are ethmoidal sinuses. Ethmoidal sinuses. So very easy, very simple question. This is maxillary sinus. So arrow is indicating towards maxillary sinus. Nothing fancy, very easy. So correct answer is maxillary sinus. This is Waters view. What is Waters view? Occipitomental view. Okay. Next question. A 35-year-old female takes a tablet of aspirin for her headache. The patient was having headache, so she took a tablet of aspirin for the headache. Later, she presented with wheezing and breathlessness. Patient was having discomfort in the chest with the wheezing sound and difficulty in breathing. Breathlessness, that means patient got the asthma attack. So on taking aspirin, patient was having the asthma symptoms. These symptoms are most likely due to which of the following? Options are IgE release, nasal polyp, drug interaction, extrinsic asthma. Now the examiner framed the question in such a way so that you get confused. But basically, what is the correct answer here is the nasal polyp. Let me tell you how. So examiner want to mention you about one triad that is known as Semter's triad. This triad consists of aspirin intolerance, asthma, and nasal polyp. So a patient of nasal polyp with aspirin intolerance and asthma is having the Semter's triad, which is consist of three parts: aspirin intolerance, asthma, and nasal polyp. So look out at the question. The patient is having aspirin intolerance with the symptom of asthma. These symptoms are most likely due to which of the following? So examiner want to indicate about a triad that is known as Semter's triad. So the correct answer here will be nasal polyp. Because the patient is having nasal polyp, already patient is having asthma. So whenever he or she is taking the aspirin, the attack will precipitate, there will be nasal blockage and other symptoms. So symptoms are because patient was having already nasal polyp and chest also get asthmatic attack. So patient was having breathless and breathing. The correct answer is nasal polyp. Don't get confused by IgE release, drug interaction, and extrinsic asthma. Next question. A patient who is teacher by profession presented to clinic with a complaint of hoarseness of voice. So patient who is teacher having the hoarseness of voice. What is the possible diagnosis in this patient? So whenever a word like teacher, singer, these come, teacher or singer, these words come, we always, and patient is having hoarseness of voice, always think of vocal nodules. What is vocal nodules? This is a rough diagram. This is my epiglottis. So vocal nodules are tiny nodules present at the junction of anterior 1/3 and posterior 2/3. So what are vocal nodules? Typically they are present in the teachers or singers who have the chronic, in long phase they are having the voice use, like the patient who are singer, patient who are teaching, who have the continuous habit of talking. So in that case, there will be tiny nodules formed at the junction of anterior 1/3 and posterior 2/3 of vocal cords. And these nodules are known as vocal nodules. So the correct answer whenever there is a question arising like teacher or singer with the hoarseness of voice, always think of vocal nodule. Don't get confused in any of the other option. Now, what is the treatment of vocal nodule? It is voice rest. It is not microlaryngeal surgery, it is voice rest or speech therapy. Ask the patient to rest properly. These nodules may revert back to normal. So the treatment of choice is voice rest or speech therapy, not microlaryngeal surgery. If examiner is indicating saying the vocal polyp, what is vocal polyp? If suppose over the vocal cords, there is a red fleshy mass, pedunculated, red fleshy pedunculated mass is present, which is more than 3 mm. So that is vocal polyp, and in vocal polyp the treatment of choice is microlaryngeal surgery. So vocal polyp, the treatment of choice is microlaryngeal surgery, and they are produced because of sudden vocal abuse. Like suddenly we shouted very loudly. So sudden vocal abuse will produce the vocal polyp. whereas the the nodules is by the chronic vocal abuse, not by the sudden but the chronic vocal abuse. Understood? So the correct answer whenever there is a teacher with a hoarseness of voice, vocal nodules. Rinke's edema and vocal cyst we'll discuss later on, but here the correct answer is nodule. Next question. A 25-year-old female patient, always look at this, 25-year-old female patient, came with complaint of decrease in hearing, that is conductive hearing loss. Conductive hearing loss means pathology of either external ear or middle ear. And pulsatile tinnitus. Now, whenever this word comes, tinnitus, that is pulsatile. There is only and only one condition where there is pulsatile tinnitus. I'll not read out the question completely, but whenever I get this word pulsatile, that means it is pulsatile form, like the blood is flowing. So pulsatile tinnitus, there is only one condition in ENT where the pulsatile tinnitus is present, that is glomus tumor. Now read out the question again. On examination, tympanic membrane appeared red and bulging. So tympanic membrane appear red and bulging. What would be the diagnosis? I have already made out to a conclusion. The correct answer is glomus tumor. How come? It's a female patient with a conductive hearing loss. That is a pathology in the middle ear or external ear with the pulsatile tinnitus. There is only one condition where there is a pulsatile tinnitus, that is glomus tumor. Whenever you look this word, always think of glomus tumor, nothing else. Tympanic membrane appeared red and bulging. It may appear red and bulging. What happens is, suppose this is your external ear. This is canal. This is my tympanic membrane, and this is my middle ear central chamber. And we all know here is the jugular bulb downwards, and there is a internal carotid artery also. So the glomus tumors are the tumor which are arising from the paraganglionic cell. They are appearing like a red bulge just behind the tympanic membrane in the middle ear. So tympanic membrane may look red, may look bulging because they are the tumor. These are the tumor which are arising from paraganglionic cell. They will have typical rising sun sign. What is rising sun? Like a sun is appearing. Sun is, so if you look out at the tympanic membrane, so there will be some reddish appearance like a sun is rising. Look like this. And this glomus tumor, what are the other things? This is also a benign tumor. It is locally invasive. It also present with profuse bleeding. Why profuse bleeding like angiofibroma? Because it is also having no tunica media. There is no muscle layer in the blood vessel. So that's why whenever the tumor is there, it may bleed profusely. So again, what are the things which are contraindicated here? Biopsy, digital palpation, okay. What is the treatment for the glomus tumor? Treatment is again surgical excision. And what is the peculiarity? It is having the pulsatile tinnitus. So pulsatile tinnitus with the conductive hearing loss, tympanic membrane, there is rising sun reflex or sign, tympanic membrane appear red and bulging. Always think of glomus tumor. Look out at the other option. We may get confused by looking at the other options also. It can be acute otitis media. Because tympanic membrane will be red, bulging, there will be conductive hearing loss. It can be chronic otitis media. But in both these conditions, there will be no pulsatile tinnitus. There could be tinnitus, but it will not be pulsatile. So what is a differentiating feature out of all these options? The pulsatile tinnitus is the key word. So whenever you read out this pulsatile tinnitus, always think of glomus tumor. Because all other conditions like conductive hearing loss, tympanic membrane, red, female patient can be fulfilled by acute otitis media, chronic otitis media. But the pulsatile tinnitus is present only in glomus tumor. Understood? Now, which type of tracheostomy tube is used in ICU patient? Whenever a patient is in ICU, that means the patient will need prolonged ventilation. That means patient will stay in ICU for long. So we have to use something which is using the prolonged ventilation. And if we do the prolonged ventilation, there are always chances of aspiration. Chances of aspiration increases if we put the endotracheal tube. So the saliva, the oral cavity bacteria through this endotracheal tube can go into the lungs, can produce the pneumonia. So what we need to do, we have to prevent the aspiration. So in ICU setting, what is the tube is preferred? There is one tube, one tracheostomy tube with a cuff. With a cuff at anterior end, which can be inflated by pushing the air. 3 to 4 ml of air we push in this cuff, so this will cuff and inflate and thus block the airway. So there will be less chance of aspiration. So in ICU setting, the tracheostomy tube is cuffed tube, mainly made up of portex. So it is portex plus cuffed tube. Suppose this is a patient. This is my neck, this is my shoulder. So what we have to do, what we are looking for, we have to use a tube inside, which is going inside, which is having a cuff, here, so that can be inflated, so that whatever is trickling from the oral cavity pharynx can't go down into the lungs. So to reduce the chance of aspiration, what we use is cuffed tube. So correct answer is cuffed tube. Metallic tube is not used. Metallic tube, the chance of aspiration are high. A person with Rinke's edema will have which are the following symptoms? Dysphagia of solids more than liquid, dysphagia of liquid more than solid, diplophonia or dysphonia. Now, Rinke's edema. We firstly try to understand what is Rinke's edema. There are 4 layers in the vocal cords. The outer layer in the vocal cord is epithelial layer. Then comes superficial lamina propria. Then come vocal ligament. Then comes vocalis muscle. So what is Rinke's edema? The patient who are like chronic smoker or something like that is a collection of myxomatous tissue in the subepithelium layer. So that is known as Rinke's edema. That will give a bulge here because of the collection of the myxomatous tissue. And and the symptoms produced here is diplophonia, which is peculiar of this Rinke's edema. Because what happened, because of this myxomatous tissue, there will be 2 sounds like heard of different frequency, because the one vocal cord which is having the Rinke's edema will produce a sound of different frequency as compared to normal. So the characteristic feature of Rinke's edema is diplophonia. What is diplophonia? Difference in frequency of the sounds. Since it's a disease of vocal cord, so there will be no dysphagia in Rinke's edema. Firstly. Secondly, there is diplophonia, which is a characteristic feature of Rinke's edema. And it is mainly present in smokers. In patient with laryngopharyngeal reflex, where there is lot of gastric reflex. Okay, so Rinke's edema is present in the smokers. LPR characteristic feature is that diplophonia. It is collection of myxomatous tissue in the subepithelium layer. And the treatment is stop smoking, firstly. PPIs, and if not resolving, then microlaryngeal surgery. Okay. Next question. Lacrimal sac is present in which wall of the orbit? Very simple, very simple. Suppose these are 2 eyes. This is my nose. So what is a lacrimal sac? We all know in the eyes there is upper canaliculi, lower canaliculi forming the common canaliculi. From that, there comes a lacrimal sac, and by means of nasolacrimal duct, it drains into the inferior meatus into the nose. Okay, here comes the inferior meatus into the nose. So this is my lacrimal sac. Okay, and this is my eyes of both the sides. Okay, so by easily you can see, suppose this is my orbit of both the sides. So lacrimal sac is present in which wall? Medial wall. Nothing fancy, very, very simple. So lacrimal sac is present in the medial wall of the orbit. You can see this is the orbit, this is the medial wall. This is the roof of orbit, this is the lateral wall. So this is the medial wall. And lacrimal sac is present in the medial wall. Very simple, nothing fancy. In a patient with Ramsay-Hunt syndrome, which ganglion is affected? Firstly, what is Ramsay-Hunt syndrome? Ramsay-Hunt syndrome is nothing but herpes zoster oticus. What is herpes zoster oticus? It consists of three symptoms. Firstly, there is profuse ear discharge, recurrent ear discharge. There will be facial palsy, and there will be vesicular eruptions. So herpes zoster oticus, which is an herpes zoster infection in the ear, affecting the ear, causing the chronic suppurative otitis media, with also affecting the facial nerve, producing three symptoms: profuse ear discharge, facial palsy, and vesicular eruptions. So that is also known as Ramsay-Hunt syndrome. So basically, Ramsay-Hunt syndrome is affecting facial nerve. Which is the ganglion involved in the facial nerve? Geniculate ganglion. Very simple, nothing fancy. So what is the correct answer? With Ramsay-Hunt syndrome, which ganglion is affected? Geniculate ganglion, because Ramsay-Hunt syndrome is affecting the facial nerve. Let's discuss little bit about the facial nerve course to make it understand better. Suppose this is abducens dominatus. This is my facial nerve, which is coming out from the brainstem, from the pons. Then it is traveling. It is entering into internal auditory canal, that is internal acoustic meatus. From the internal acoustic meatus, it is making a sharp turn, forming a genu, that is known as first genu, also known as geniculate ganglion. And from there it is making the horizontal part, entering into the ear, then forming the second genu, and then forming the vertical part in the mastoid going in the ear. So this is my middle ear like this. So geniculate ganglion is the first genu of the facial nerve. And from this genu, what is the nerve? What is the branch that is coming out? That is GSPN. Greater superficial petrosal nerve, which is supplying the eyes lacrimal glands to secrete the lacrimation, to secrete the tears. Okay, so this is the course basic simple understanding of the facial nerve. Facial nerve, after coming out of the internal acoustic meatus, taking a sharp turn, which is forming the geniculate ganglion, and from the geniculate ganglion nerve coming out is GSPN. Then it is entering into the middle ear, forming the horizontal part. Then another nerve is coming, which is known as nerve to stapedius, and the third branch is chorda tympani now. Chorda tympani and nerve to stapedius. So basically, Ramsay-Hunt syndrome, what is happening is whenever the facial nerve is this coming like this, facial nerve traveling, so herpes zoster virus attack at the geniculate ganglion, producing the facial palsy. So in Ramsay-Hunt syndrome, the geniculate ganglion will be affected. Next question. In view of mucormycosis, which of the following options has the least possible cause? So basically, what examiner want to ask, mucormycosis, what are the causes? So look out at the options. Uncontrolled diabetes, yes, seems to be a cause of mucormycosis. Broad spectrum antibiotic, no, antibiotic will decrease the infection. So why would mucormycosis occur if we are taking the broad spectrum antibiotic? No. Neutropenia, that is deficiency in neutrophil count or decreased neutrophil count. Definitely it can lead to immunodeficiency, that will lead to mucormycosis. Prolonged use of steroids, yes. See, look out at the option A, C, D. uncontrolled diabetes, prolonged use of steroid, neutropenia, these all conditions except this condition are producing the immunocompromised state. So the correct answer here will be following option is the least possible cause. Least possible cause will be broad spectrum antibiotics, whereas all other causes may lead to immunodeficiency, immunocompromised state that will further result in mucormycosis. Very simple question. Last question. A patient present with complaint of unilateral nasal obstruction associated with watery nasal discharge or nasal bleeding, and the diagnosis of inverted papilloma has made. Patient has already written what is that disease. So it is inverted papilloma. Now, what is true regarding the following condition? So basically, examiner what is true regarding inverted papilloma? It is malignant, it is benign and non-invasive, it is benign and invasive, none of the above. The correct answer is benign and invasive. See, inverted papilloma is a disease which is benign. It is locally invasive. Most commonly, it is arising from lateral wall of nose. Also known as Cnidarian membrane. And it is a pre-malignant disease. That is, chances of squamous cell carcinoma are there. So it is a pre-malignant disease, may lead to squamous cell carcinoma if not treated. It is highly recurrent disease. So because it is highly recurrent, what we have to do? We have to surgically debride the disease completely. Even the point where it is arising, we have to remove that bony part also. Suppose it is most commonly arising from the lateral wall of the nose. So we have to remove that part, that area from where this tumor is arising. So surgical debridement is treatment of the choice, not the first. So inverted papilloma is a tumor which is benign and locally invasive. It is an aggressive tumor. It spread locally. It is a pre-malignant disease, most commonly arising from the lateral wall of the nose. So it is benign and invasive. What are the other name of this tumor? Other name of this tumor is Ringer's tumor. What is the peculiarity of this tumor, Ringer's tumor? The tumor is growing inside, inverted. Into stroma. That means it is embedding into the stoma. Okay. So that's all about this inverted papilloma. I hope everything is clear. So again, this was the FMGE 2023 ENT recall session by Dr. Prateek Garg. Thank you.